So you may begin, Rebecca.
Okay. Good evening, everyone. So I'm Rebecca Karumba, and I'm going to present on myopia progression. Let's proceed to our first slide of the presentation. Yeah, so myopia is a refractive error. I hope most of us understand that myopia is a refractive error whereby the image that is the image of an object that one person is looking at is formed in front of the retina instead being formed on the retina as it's supposed to be. So this results to blurry distance vision. And myopia progression, having explained what myopia progression is now when the severity of myopia increases over time. So, as we can also say that it's when the axial length of the eye increases over time. Hence, the image becomes more blurry over time. So, it typically occurs during childhood and adolescence, and we have the age limit at 13 years old because that's when the eye is fully grown. Yeah, because we said that it's increase in the axial length. So when the eye grows, the axial length is constantly increasing. So up to 13 years of age, that's when for most children, their eyes are already fully grown and the axial length is finished growing and the growth factors are now withdrawn. So it's rare for us to have an increase in the axial length. Yeah, let's have the next slide. Yeah, so we have patterns of myopia progression. So, because I explained that myopia progression is due to the gradual increase of the axial length, causing the image that is entering the eye to be formed in front of the retina. So we have the progression may occur in different patterns. So we have rapid progression. For some, the progression happens quickly over a short period of time, which is what we are going to actually focus on more because we have to when this progression is fast enough, you're going to have more effect that are on the eye. Yeah, so we have a uh, slow progression, just as the word suggests. This one happens gradually and slowly over a period of time. We have early onset progression. This is at a younger age. Late onset progression at a later age. And then we have stabilized myopia. At this point, the myopia has finished progressing and now it is stable. It's no longer increasing. Yeah. So we have myopic creep. This is for adults from the ages of 30 and it's mostly lenticular, but it's also rare. It's rare to find such myopic changes due to the lens, even at that age. But for rare circumstances, we have myopic creep. Yeah, let's have the next slide. So, how do we assess myopia progression? So, the first thing and most important thing is review of history. Through review of history, we will be able to know whether the myopia is progressing or not. One single test cannot warrant that myopia is progressing or not, because for a progression to happen, we must see the start point or an earlier point and the next point of the progression. And then we have visual acuity, which tests the quality of vision in a person. And then we have cycloplegic refraction, sorry. And we have cycloplegic refraction because cycloplegia relaxes accommodation, hence enables you to have effective results, especially for children who are our key area of focus at this point. And then we have axial length measurement. Yeah, axial length, as we had mentioned before, axial length is a major factor in myopia progression. Yeah, next slide, please. Yeah, so we have the etiopathogenesis of myopic progression. So we have genetics. In most cases, for myopia itself, we would have in most cases you would find that there's a family history of myopia, hence being a genetic condition, which will also predispose one person to be able to have would predispose myopia progression. And then we have environmental factors, near work and reduced outdoor time, which have in various times shown to increase myopia, the amount, the level of myopia over time. And then we have accommodation lag, and accommodation lag increases myopia in a way that I am going to, in a way that is connected to the next point, which is hyperopic defocus. So I will explain hyperopic defocus better in pictures, but hyperopic defocus is when the image is now formed behind the retina. And because this is a child's eye and the eye is growing, what will this do? This will signal the brain that the eye needs to grow longer so that it can accommodate the image that is being formed on the retina itself. So accommodation lag also causes hyperopic defocus because for a patient with accommodation lag, the image is also forming behind. The whole image at this point is forming behind the retina. So we causing a higher chance for myopia progression to occur. And then we have natural eye growth, which we have mentioned severally before. That's for the axial length to continue increasing, we would have natural eye growth. Then we have early onset of myopia. When there is early onset of myopia and the eye is still growing, then we have there is a higher chance for myopia progression to happen. Let's have the next slide. Next slide. This is the image that I was talking about. So we have the first figure there with an uncorrected myo. So we have three arrows to be able to show us how the image forms in the eye for a myo that has not yet been corrected. So we have a horizontal the horizontal arrow that is forming in front of the retina. And then we have the two arrows above. One is just on the retina and the other one is outside the retina. So for the topmost arrow that is outside the retina, you will realize that this is what is going to cause a signal to the brain that the some parts of the image are still not on the retina. And what will this indicate to the brain? The eye needs to grow more. So more factors of growth are placed to make the eyeball grow longer. But one thing you realize is when the grows longer, it doesn't grow on a flat level. It will still grow on a curved level. Therefore, we will continue having an increase over time because when the image is finally falling on the retina, now we can see what the traditional correction does. The traditional correction makes the image, we can see the horizontal line is now falling on the retina. But we will see on the other side, those arrows are falling outside the retina. So what will it do? It will still make the brain to receive signals that other parts of the, I'm sorry, I had a small network hitch. I hope that's okay. Is it okay?
Yes, you may continue, Rebecca.
Okay. So for the traditional correction, as I was saying, you'd find that the middle part, the middle part or the center part of the image is being focused on the retina, but the other parts of the image are falling outside the retina. And what will this cause? This will cause for more, the brain will be signaled for more growth. And this will continue increasing the size of the eye. The axial length of the eye continues increasing. And hence we will have myopia progression. Let's have the next slide. There we have management, and the management based on what we have already seen and what we have discussed about myopia and myopia progression. So to manage myopia progression, we are going to look at three ways, three key parts. So the first one is scleral strengthening. The other one is increasing dopamine levels in the RPE. And what do dopamine levels do in scleral strengthening? They will reduce the amount of growth in the retina. And then we have peripheral hyperopic defocus techniques. We saw the hyperopic defocus that's happening in the periphery. So what this is saying is that we are going to have to reduce the hyperopic defocus that we have on the periphery. And when we have hyperopic defocus on the periphery, what we do is what we are going to do is going to counter what is happening there. So what we do is myopic defocus. And I hope this doesn't get you confused. We use myopic defocus to be able to do away with hyperopic defocus. So what is happening is hyperopic defocus, and what we are doing is myopic defocus to be able to neutralize the defocus that we have at the periphery. Let's have the next slide. Okay. Yeah, can we go to the previous slide where we were before? Oh yeah, I had just finished explaining peripheral hyperopic defocus techniques, and I also mentioned that we have myopic defocus to be able to neutralize the hyperopic defocus that is in the eye. Yeah, then you can move to the next slide. Yeah, so we have various options based on the three techniques we have seen before. We have options that are going to help us achieve that. So we have the options below. So we have number one, we have optical devices. The optical devices, we have DIMS in full defocus incorporated multiple segment spectacles. We're going to look at that in a short while, and also multifocal contact lenses. Then we have orthokeratology, which I'm going to explain right away. Orthokeratology is achieved through contact lenses that are formed in a way that they will shape the cornea of the eye, or the front part of the eye, which is the cornea. What they do is they flatten the cornea, which is not flat, is yeah, the force from the contact lens is able to make the front part of the cornea to be flat. And when it's flat, this changes how light interacts with the eye. So we are not going to have that image form in that way, whereby at the ends it is going to form outside the retina. So the image is going to be more of flattened in the way that it doesn't fall outside the retina, hence reducing the signals that are sent to increase the axial length of the eye. And then we have progressive addition lenses. When if we remember in a previous slide, we saw that accommodation lag is part of the reasons why myopic myopia progression will happen. So progressive addition lenses are going to counter accommodation lag, which will therefore create a myopic defocus on the eye. And then we have pharmacological means, whereby we would use low dose atropine eye drops. If you remember, in the first two techniques, we had strengthening of the sclera. The atropine eye drops will do that. And then we had a next one, a next one we had, which was in stimulating dopamine being released in the retina. When these two things happen, when dopamine is released in the retina, it is going to reduce the growth, the stimulation of growth in the retina. Hence, you're not going to have the axial length constantly increasing. And then we have combination therapies. In most cases, we will, the methods are combined based on effectivity, and these methods can be changed. For instance, atropine is rarely used alone. It will be used in combination with an optical device, maybe the DIMS lenses, the defocus incorporated multiple segment spectacles, or it will be used with multifocal contact lenses. And this is going to depend based on outcomes, because what are we trying to do? We are trying to reduce the axial length increase. Therefore, it's going to be based on performance, which one works best at what point. Yeah, let's have the next slide. Yeah, so this is the DIMS, the lens that I had said I would expound more on from the last slide. So when you look at how this lens is formed, let us look at the second figure. We have the central optical zone. The central optical zone right there is for distance vision. This is the actual refraction that you find when you're refracting a patient using either a retinoscope or after subjective refraction and everything. This is where we are going to have that power that you will find there. And then we have multiple segments of central myopic defocus. So if you remember what myopic defocus was, myopic defocus helps us neutralize hyperopic defocus. So on the periphery towards the end, in the middle, we are going to have the distance, the actual distance vision. And then on the sides, we are going to have the myopic defocus, small lenses incorporated to be able to cater for the defocus as it is curved in the periphery. So if you look at the first figure, we have been looking at the second figure. If we look at the first figure, you will see that when you view this lens from the front, you will actually not see these small portions of myopic defocus segments. You're going to see a flat lens, but you'll be able to know that this is the technique that is used to make the lens work. Yeah, let's have the next slide. Yeah, so we have multifocal contact lenses where we have from the figure we have the dark purple area, which is called treatment zones creating myopic defocus. And then we have the light purple zones, which are the correction zones. If you look at this, the technique is similar to the DIMS lenses, such that there is an area that is dedicated to focusing on distance vision, and there's an area that is also dedicated to make sure that the image that is being formed is not formed beyond the retina to signal growth of the eye, hence more increased axial length. Yeah, let's have the next slide. So this is what the optimal correction should look like. So if you remember the figure that we had access to before, we had only the first two figures, whereby I showed you uncorrect and what an uncorrected myope, what's how the image of an uncorrected myope occurs in the retina, and then we have the second one, which is the traditional correction for a myope, and then the third image is going to show us the optimal correction, what we actually need so that myopia does not continue progressing. So for the optimal correction, you will notice that the three arrows, of all the three arrows, none is falling outside the retina. So none is signaling need for more growth of the eyeball, none is signaling for an increase in axial length. And therefore, if this happens, we will have controlled myopia progression. So I hope this is going to make more sense when you connect it with for example, the DIMS lenses that we have seen before. This is what we are trying to achieve with the DIMS lenses. This is what we are trying to achieve with the multifocal contact lenses, so that we will ensure that the image is not causing a hyperopic defocus. Let's move to the next slide. Yeah, so we have what if we do not get to correct this? What if maybe a patient is not able to access you and be able to have it controlled? What do they risk? What risks do they have? Yeah. So we have the first one, which is retinal detachment. Remember, the eye is continuously growing, and as it's continuously growing and rapidly so, remember we were talking about the rapid progression. So when it's doing this, in some instances it's increasing more than it should, and when it continues increasing in length, what does it do? It causes tension on the tissues of the eye. Due to the tension, we are going to have the vessels, sorry, we are going to have tears, we are going to have the vessels of the eye affected, we are going to have various issues that are related to tension in the eye. So these issues will include retinal detachment because of the constant pull. We would have myopic maculopathy or myopic macular degeneration, which will end up affecting the tissues and the blood vessels at that point. And then studies have also included that glaucoma and cataracts, early cataracts, have been accompanied, have been related to increased axial length, which is myopia progression. And then we also have myopic choroidal neovascularization because of the constant pulling on the eye due to the tension caused by constant growth. Yeah, so I hope that we can see myopia progression, the risks it poses, and how we can try to control it. And another thing I would like to mention is that there is a standard way that we could look at myopia progression to be able to know that it warrants close attention. Because you remember when we were looking at the patterns, we saw that we are focusing on rapid progression. So typically, we would look at it in terms of in within six if within 6 months we will have had a significant change in the refractive power of the eye, which means it's more myopic, then that warrants that we have a rapid myopia progression, which needs to be controlled by the methods that we have mentioned, the pharmacological and the optical methods that we have mentioned. So this calls us to also be cautious, especially in diffraction of the younger population or children, whereby they are at risk of many other conditions as we have seen before, which will impact not just the refractive status of the eye, but also other conditions such as maculopathy, retinal retinal detachment, and all those that we have mentioned before. And I think I have come to the end of my presentation. And in case of any questions and any discussions, you're welcome.
All right. Thank you, Rebecca, for that nice presentation that we have had. And one thing that I'd like to maybe mention is that myopia progression basically works with what is working for the patient. When we're dealing with management, it is what is our interest in this patient. The major interest for us practitioners should be, does this management strategy work for this patient? So it is patient based. And then another thing that we need also to note is that atropine, the reason why we use 0.01% is because we are targeting adverse effects to be less, because we all know that atropine is atropine is uh, atropine is cycloplegic, or it's a dilator. So when we have a higher percentage of atropine, we are expecting that this patient will actually be having light sensitivity issues. And so we have to use a lower dose of atropine to reduce such kind of cases where we have a patient adversely reacting to this management strategy of atropine penalization. And then also the reason why you use a low dose of atropine is that we are trying to minimize the rebound effect. Rebound effect occurs when, let's say, the myopia was progressing by 0.25 diopters, minus 0.25, minus 0.25 diopters per year. But now you find that when you stop this atropine, the patient progresses by around minus 0.50 diopters per year. That is called rebound. Now, to prevent this rebound effect, we have to first use a low dose of atropine. That's why we use 0.01%. But if we see a good response, then we may rise to around 0.025%. But if we go to around 1% atropine, yes, the effect will be reduced by a significant amount. But once the atropine is stopped, there's a possibility of a rebound effect for this patient. And therefore, we will have done more harm actually than good to this patient. And then we also need to note that compliance is key, very much key in myopia progression management, because without compliance, then the patient is unable actually to, the patient is unable to see the effect of this management strategy if he or she does not actually comply adequately to this management strategy that we're giving. And therefore, it's a call to parents, especially because if you're dealing with the kids, then the compliance is basically based on the parent majorly. So we need to understand how to talk to this parent and tell him or her that compliance is key to see results. One last thing that we also need to know is that follow-up is very crucial in management of myopia progression. We only know whether a management strategy is working if we do follow-up for this patient. So we need to set a timeline. At what frequency do we follow up for this patient that we are treating for myopia progression? So follow-up also helps in, it can also help to dictate compliance for this patient, depending on the management strategy that you give. So assuming we are using atropine penalization as a management strategy. Now you start penalization today in April, and you expect that by 6 months, we will at least be able to see the progress of this progression. Now, if the myopia was progressing by minus 0 to 5 per year, we expect that when we involve this management strategy, then we are able to reduce this progression either by half or by a quarter. So if it was minus 0 to 5 diopters, then we expect the progression now to be minus 0.125 diopters. So we have reduced the progression by half. So if there is marked reduced rate of progression of this myopia, then we are comfortably able to say that this management strategy is working for this patient. But if there is no change after that period of time, then we are able to decide, do we change this management strategy, or do we complement it with another? Remember, you had mentioned something about combined strategies. So we need to understand, do we change or do we complement this strategy? And then now, my question is there a guideline or maybe something that we need to discuss in terms of when do we know that this is the management strategy for this particular age? One thing you had mentioned was progressive additional lenses. Now, how do we manage, let's say, a child that is 3 years old? Do we also give him or her pulse? Or if it's an adult, because you mentioned something about adult progression, how do we manage an adult? Do we also give him or her atropine, or do we give him or her spectacles? So how do you decide what to give to a patient based on age? Thank you. Please unmute, Rebecca. Please unmute.
Sorry. Yeah, as I was saying, thank you for that question. For adults, if you remember one thing I explained when I was talking of some of the progression stages, for example, we have sometimes which happens, which is myopic creep. For those who are even up to 30, 40 years old, sometimes some progression may be seen. And in most times, this cannot be attributed to growth because the eye is pretty much done growing. So for such ages, you would find that it's more of the lenticular changes and other aspects of the eye. So the first thing I would like to mention and insist on is establish the cause. And I think this also talks more of what you had added, that managing, we have to understand why using this and this, if it's effective and all these things. So the first thing, establish this. So the first thing I will tell you, for an adult, we are sure that this is not growth that is happening. We are sure that the axial length is not increasing because of growth. So we have to look if these are maybe some pathological conditions that would need different intervention apart from optical devices, then optical devices are not going to be used. For in most cases, when you have lenticular changes causing myopia progression, and when we have that, I think this calls for, sometimes it is sometimes it is the changes that are occurring to the eye, maybe because of time, age, and sometimes there are many other factors sometimes that we can't control. So sometimes it's best that we give the traditional lenses. And I don't think there's much harm in giving someone who is an adult the traditional lenses, because we are we are not going to we are not going to stimulate hyperopic defocus at this age. So there's nothing to fear for giving a full correction and causing a hyperopic defocus. So largely, I would still say it will depend on what is happening to this adult. And then we talked of the child. You asked of the child with the PALS, the progressive addition lenses. So for a child at 3 years old, I also still think that there are many factors that will get in, and that could be another whole presentation. But for a child, which you gave an example of 3 years old, we would have to look at various factors. We would have to look at how much the eye has grown. We will have to look at what needs to happen to the eye, because at 3 years old, I am pretty sure that there's so much change that we could be still expecting in the eye. So these things need to be put into focus. And sometimes, if you remember some of the causes, some of the reasons why, um, we would have this progression, it's because of the already the presence of myopia already. So if myopia is there already present, and we look at the size of the eye and we see that it's almost in full, um, it's almost fully developed, then we will have to give the pulse. So I would still largely say that look at the circumstances that are surrounding you. Thank you.
Thank you, Rebecca. In the absence of any other questions, we thank you all for attending the meeting, and we are hoping that this has been a great session. See you all next Thursday. Thank you so much.
Thank you too.